We have four major classes of anticoagulant drugs. Heparin and Warfarin have their own specific mechanism of action. In addition to them, we have direct factor II inhibitors, so-called direct thrombin inhibitors, because factor II is thrombin, and another class is direct factor X inhibitors. All drugs act just on secondary hemostasis. All of them inhibit formation of a thrombus, so they all decrease the risk of thrombotic events. Because they all act on secondary hemostasis, primary hemostasis remains intact, so bleeding time and platelet count usually remain normal. But each class has its own mechanism of action, and to explain this, we have to recall hemostasis. So, if damage to endothelial cell occurs, endothelin that was contained inside the endothelial cell will be released into the bloodstream and will cause transient vasoconstriction. After vasoconstriction, organism has to immediately cover and repair the damaged area. In order to do this, endothelial cells release from Weibel Palade bodies huge amount of von Willebrand factor. In the bloodstream, von Willebrand factor binds to subendothelial collagen under the disrupted endothelial cell. After that, platelets come to the site of injury, and by the specific receptor GP1B, they bind to von Willebrand factor, and exactly this simple step called platelets adhesion. After the adhesion, platelets become activated. In response to this, they undergo shape change that results in their degranulation. With degranulation, platelets release the content inside them, including the dense granules that contain ADP. ADP that is released into the blood acts on ADP receptor on platelets and activates it. Activation of ADP receptor forces platelets to transport GP2B3A receptor to the surface, where GP2B3A serves as binding site for fibrinogen. In addition to this, platelets from prostaglandins by COX enzyme begin to produce thromboxane A2, and the function of thromboxane A2 is to promote aggregation. When fibrinogen notices a GP2B3A receptor on platelet surface, fibrinogen immediately binds to GP2B3A, and when another platelet comes to the site of injury, platelet immediately binds by GP2B3A to fibrinogen, and this process is significantly accelerated by thromboxane A2. This binding occurs over and over again until platelet plaque will be formed, and exactly this gathering of platelets at the site of injury called aggregation, and aggregation results in formation of a platelet plaque. But platelet plaque is weak, and to stabilize it, to make it formidable, we have secondary hemostasis. The function of the secondary hemostasis is to make from weak platelet plaque a formidable structure that's called thrombus, and the thing that makes this platelet plaque formidable is conversion of unstable fibrinogen into a stable fibrin. Secondary hemostasis is provided by coagulation factors that form coagulation cascade. The central factor of coagulation cascade is factor X. The goal of both intrinsic and extrinsic coagulation pathways is to activate factor X. Intrinsic pathway consists of factors from 12 to 8. Extrinsic pathway consists of just factor 7. Activation of factor X results in activation of factors 5, 2, and 1. Factor 2 called prothrombin that with activation becomes thrombin, and factor 1 called fibrinogen that with activation becomes fibrin, and exactly fibrin makes from platelet plaque a formidable thrombus. So secondary hemostasis converts platelet plaque into a thrombus. To assess the extrinsic pathway, we use prothrombin time and international normalized ratio. For assessment of intrinsic pathway, we use partial thromboplastin time. The first agent is heparin. Heparin is parenteral agent that activates antithrombin, and by antithrombin activation, heparin inhibits the activity of factor 2 and 10. So what we have to know is that the activity of factor 10 and 2, so-called thrombin, is regulated by a specific molecule called antithrombin. Antithrombin regulates the activity of these two factors by inhibition. When we prescribe heparin, heparin activates antithrombin. In response to this, inhibitory effect of antithrombin becomes more potent, so factor 2 and 10 becomes less active. Thereby fibrin formation will decrease, and without fibrin, thrombus cannot be formed. It was estimated that generally heparin affects intrinsic pathway more than extrinsic, and because of that, we monitor the effect of heparin by prolongation of the partial thromboplastin time. Another important concept is that in case of heparin overdose, we have to use protamine sulfate. The concept here is that heparin is negatively charged molecule, and protamine sulfate is positively charged molecule. And because opposite charges attract, once protamine sulfate is infused, it immediately binds to heparin and inactivates it. Thereby, antithrombin activity decreases and activity of factors 10 and 2 increase. The side effects of heparin is bleeding, and which is by far more important, it's heparin-induced thrombocytopenia. Heparin can be used during pregnancy because it do not cross placenta barrier. And as we said, because heparin affects mostly intrinsic pathway, we monitor the effect of heparin by prolongation of the partial thromboplastin time. Warfarin is peroral agent that inhibits vitamin K epoxide reductase, and by this warfarin decreases the activity of vitamin K dependent clotting factors. So the concept here is that coagulation factors as factor 2, 7, 9 and 10 for their proper function require additional post-translational carboxylation that is provided by epoxide reductase, and epoxide reductase for its function requires vitamin K. So when we prescribe warfarin is an antagonist of vitamin K. Without vitamin K, epoxide reductase cannot provide carboxylation of coagulation factors. Thereby factors 2, 7, 9 and 10 will be produced broken. They cannot perform their function adequately. As a result, coagulation cascade becomes dysfunctional, thereby thrombus formation will decrease. Because warfarin affects factor 7, which is practically the only and the major factor in extrinsic coagulation pathway, extrinsic coagulation pathway is affected the most. And because of that, we monitor warfarin effect by prothrombin time and international normalized ratio. In case if warfarin overdose occurred and prothrombin time and international normalized ratio become abnormally high, we can reverse warfarin effect by vitamin K infusion that will provide enough amount of vitamin K to reactivate epoxide reductase. Thereby carboxylation rate will be sufficiently high to provide enough amount of normal factors 7, 9, 10 and 2. As a result, the rate of a thrombus formation will increase, and because now factor 7 will be produced normal, extrinsic pathway will be active enough again, thereby prothrombin time and international normalized ratio will normalize. The side effects of warfarin is bleeding and warfarin-induced skin necrosis, which is actually a unique feature. The next class of drugs called direct factor 2 inhibitors. It's bivalirudin, argatroban and dabigatran. So with infusion of dabigatran or any other factor 2 inhibitor, they directly inhibit factor 2, that is called thrombin. And because thrombin provides the crucial conversion of fibrinogen into fibrin, with inhibition of thrombin, fibrin cannot be formed. And without fibrin, conversion of a platelet plaque into a thrombus becomes impossible. As a result, the rate of a thrombus formation will significantly decrease. Direct factor 2 inhibitors are relatively safe drugs that do not require monitoring of coagulation values. And we have to know that in case of overdose by dabigatran, we have to use idarucizumab as antidote. The concept here is that idarucizumab binds to dabigatran and inactivates it. And by this we can reactivate thrombin, that in the end will provide formation of a thrombus. And as we said, direct factor 2 inhibitors are relatively safe drugs, so there are no significant side effects. Direct factor 10 inhibitors, in contrast to factor 2 inhibitors, are peroral agents. The mechanism here is that when we prescribe apixaban inhibits factor 10, which is a central factor in coagulation cascade. As a result, the activity of the common coagulation pathway decreases. Thereby the rate of a fibrin formation decreases, and without fibrin, thrombus cannot be formed. We have to know that in case of overdose, we should use Andexanet alpha, which is basically an activated form of factor 10 that can reactivate common coagulation pathway. In other aspects, direct factor 10 inhibitors are quite similar to factor 2 inhibitors. They also do not have significant side effects, and they do not require monitoring of coagulation values. If you like content, please press like and subscribe button. All the best!